Welcome to the screencast for treatment in acute renal failure. The patient may be intravascularly depleted and require fluid, only give if assessed fully and prescribed. Inotropes or vasoconstrictors such as noradrenaline or dopamine may be utilized to increase the patient's mean arterial blood pressure to optimize organ perfusion and aid renal function. A strict fluid balance is necessary to monitor for signs of fluid overload in conjunction with blood pressure, CVP, saturations, and U&E blood monitoring. To monitor effects of fluid overload and assess for further required interventions, and assess interventions already undertaken, like oxygen therapy, in line with the prescription and the patient's condition. If acute kidney injury is diagnosed early, the administration of diuretics will aid in the removal of excess fluid and offload the patient, depending on the level of effective response, but they will not treat the underlying cause. In our area of work, the diuretics used are mainly furosemide, non-potassium sparing, and amiloride, potassium sparing, which will have a direct effect on the cardiac stability if levels become too low or high, making it essential to monitor potassium levels closely through arterial blood gases and ECG monitoring for signs of cardiac instability. As discussed in the previous screencast, an increased level in hydrogen ions will create a metabolic acidosis. To buffer them, sodium bicarbonate can be administered to manage the acidosis whilst determining the cause and treatment necessary of the acute renal failure. Sodium bicarbonate may also potentially prevent muscle breakdown. In acute renal failure, there may be protein losses, lowering the oncotic pressure, resulting in fluid moving from the vascular space to the interstitial spaces, contributing to the levels of edema. Therefore, by optimizing protein levels via dietary intake, albumin, or parenteral nutrition, levels of edema and the effects of it can be reduced. The optimization of potassium levels is essential in any patient, but measures taken to correct them in those with acute renal failure must be undertaken carefully and monitored closely. If none of the previous treatments are effective, then continuous renal replacement therapy is to be considered. On our unit, the chosen mode is CVVH-DF, which is continuous veno-venous hemodiafiltration. The initial step is to insert a vas cath, which will be performed by an anaesthetist, utilising ultrasound-guided technique and asepsis. Ongoing infection control care is that of the qualified nurse. Once the filter is prepared and prior to connection, the fluid turnover is calculated, which is weight related, 35 ml per kilogram per hour to achieve optimum fluid and solute removal in accordance with local evidence-based guidelines. The solutes are removed via ultrafiltration, convection and diffusion. Ultrafiltration is a method of convective transport, which is the movement of water and permeable solutes pass through a semi-permeable membrane with a force of hydrostatic pressure. Diffusion is the active solute and waste removal across a semi-permeable membrane from an area of high concentration to an area of low concentration. Therefore, a concentration gradient is constantly necessary for this diffusion to occur. These two processes are both non-selective of the solutes that are removed, so it is imperative to monitor urea and electrolytes closely, especially potassium, to ensure safe levels for cardiac stability. Please complete the following questions.